The broadcast is now starting. All attendees are in listen-only mode.
Hi everybody, thank you for logging in and taking part in the webinar. This is a webinar that is hosted by RIAT-ISA and the Coalition for Children Affected by AIDS. And in this webinar, what we'll try and do is to explore the latest research findings, really examining the role of social protection that it plays on HIV outcomes, and examining the implications for how we design, how we fund, and how we deliver the support that we give to communities that are affected by HIV and AIDS. I will be chairing the session. I'm Noreen Huni, the Chief Executive Officer for Regional Psychosocial Support Initiative, usually known as REPSI. I want to most appreciate those who are coming and joining the webinar for the first time. Nothing much to stress about. You'll find that on the control panel on the right side of your screen, that's where you can join the session. And we are going to be using the screen to manage the session. Please put the headphones on and turn up the sound so that you can hear well all the presenters. And during the webinar, what we'll do is the attendees, all of you as the audience, you'll be muted. We encourage you to send the questions that you have at any point via the chat box. You find on the right side, there's the question box. We encourage you again to try and indicate who the panelists you are directing the question to, and we'll ask them to respond at the end of the session. Should you have to step out, do not worry, because we are recording the whole webinar and we'll be able to watch it later, and we'll share with you the links of how to watch. Please note that you are not able to speak. Just send your questions in the question box. Only the panelists will speak when we've invited them to do so. So what we'll do now, just to give you a bit of introduction to the RIAT-ISA. RIAT-ISA is a regional interagency task team on children and AIDS in East and Southern Africa. This is a unique African network, which actually is a multi-sectoral partner of organization. And what it does, it has been really driven by evidence to influence global, regional, as well as national policy formulation, and including the implementation of this formulation for children and the families affected by HIV and AIDS. And the coalition, on the other hand, is a global platform that brings together funders and technical expertise. And together they really use evidence to advocate for best policy, again to influence research agenda, as well as to influence programming for children that are affected by HIV and AIDS. And just to mention that the children affected by HIV and AIDS have often been left behind, and so these two networks have come to really do a great piece of work to elevate the profile of these children. Just to take you through the agenda for the day, we'll start off with the introduction, and then we'll introduce the panelists. We'll then ask them to make the presentation, and then your question and answer is your time to voice your voice, for you to be heard. So make sure you write your questions when we invite you to do so. At closing, which is at the end of an hour, we'll have a vote of thanks for the sponsors, and most importantly to you, ladies and gentlemen who are in our audience. We'll go straight by introducing our webinar panelists. Special thanks that they have found time to be with us today. We do have Professor Lucy Kluver, who is a professor of child and family social work and in the Center for Evidence-Based Social Interventions in the Department of Social Policy and Interventions. She also has an honorary lecture at Psychiatric and Mental Health at the University of Cape Town. Then we've got Paul Carlos van Ufford, who is currently the Chief Social Policy with UNICEF Tanzania, and up to end of 2016 was occupied in that same position with UNICEF Zambia and working on social protection, child poverty, as well as public finance for children. Our next presenter that we have is Jason Wolf, who is with the Billy and Melinda Gates Foundation. Jason Wolf leads the demands and community mobilization portfolio within the integrated delivery team at the Billy and Melinda Gates Foundation. And then lastly, we have David Chipanta. He may join. We haven't seen him yet. He's supposed to give us a presentation. He hasn't come on board yet. Should he join, he will be our last presenter. He's a senior advisor in social protection within UNAIDS and is based in Geneva. He provides leadership within UNAIDS to develop and implement new and innovative high-profile strategies, the tools for mobilizing for social protection, care, and support actors. Without further ado, I invite Lucy Kluver to make your presentation.
Well, good morning, and just checking, can everyone hear me okay?
Yes.
I'll hope so. Great. So I just wanted to start really by saying that I'm just the speaker here. This research has been part of a huge collaboration, and in particular, co-authors Mark Orkin, Lorraine Scher, Ilona Tosca, Francisca Menk, Rebecca Hodes, and colleagues at UNICEF, the Coalition, and RIAT have really been integral to the ideas behind this work. But I should also start by saying that this research started rather oddly at a RIAT meeting in 2013, which was in a casino, which in Johannesburg, which is probably not the place that you would necessarily think of starting social protection research ideas. But what emerged at this meeting was that we really need to start thinking about the next generation of social protection research. And in 2012, 2013 and 2014, there was some exciting and innovative work really led by UNICEF, Innocenti and the World Bank, which showed the promise of cash transfers in reducing the infection rates of HIV amongst adolescents. But policymakers were asking questions and programmers were asking questions about how does this work in reality? What kind of combination should we really be doing? And how can we turn the cash transfer research into programmable work that can be achieved within sub-Saharan African context? If you move to the next slide. So the first real new breakthrough was thinking beyond cash transfers alone. And this shows the impact of combining cash and care, which is primarily parenting support, but can also be support from an adult such as a teacher, on HIV risk behavior. So these HIV risk behaviors were transactional and age-disparate sex, casual partners, multiple partners, and sex whilst using substances. And if you look at girls on the right in purple, you can see this is looking at incidents of new HIV risk behaviors in the past year. And this is modeled percentage probabilities. So it's controlling for a whole range of socio-demographic factors and causally reliable because it's looking at incidence rates. You can see that for girls with neither cash nor care support, around 14.5% were starting new HIV risk behaviors in the past year. With either cash or care, that dropped to around 10%, but the combination of cash plus care reduced that to around 7%. For boys, it was actually even more stark. We saw that with neither of those supports, risk behavior incidence was around 23%, reducing to around 15% for cash or care alone, and down more than half to 10% for combinations of cash plus care. So this really was our first recognition that we needed to provide social protection for adolescents that looked beyond just provision of cash transfers, which were absolutely necessary, but linked with the child psychosocial sector, child protection sector, and parenting support sectors to provide a social protection response that was relevant not only to the economic needs, but also to the developmental needs of adolescents. Can you move to the next slide, please? Now, policymakers, although we love this kind of combinations of cash and care, policymakers really demanded that we get much more specific. And this particularly came through at a meeting organised by World Bank colleagues, again in Johannesburg, in around 2014, where senior government officials in multiple countries in the region said, we want to know exactly which combinations are going to be most effective. And I'm going to show you some examples of those. So you can see that if we're trying to reduce economically driven sex for girls, that's particularly age disparate and transactional sex, the most effective combination seems to be parental monitoring, child grants, which is the child support grant, and free schooling. So with none of those, around 10.5% are starting that economically driven sex in the past year. With all three of those, that's down to 2% or less. You move to the next slide. We see slightly different impacts for careless sex, and careless sex is sex whilst using substances or multiple partners or casual partners. And we see again though that with no intervention, that's around 15% starting in the last year, but with both parental monitoring and school feeding here came as really important, that reduced down to 7%. If you move to the next slide. It also taught us, though, and policymakers emphasised that we needed to think not just about girls, but also about boys and adolescent boys. We know that at least some of the HIV incidence is being provided through adolescent-to-adolescent sexual risk. And we see here that for boys, it's actually a very similar set of predictors. Good parental monitoring, that's when parents know where their teenager is, have set rules to go home, are monitoring who their friends are and what they do with their spare time. So parental monitoring, a child grant, and free school. And we see that with none of those, 19% are starting incidents of careless sex in the last year. And with all three of those, that's reduced to 3.5%. Transactional and age disparate sex was much less of an issue for the boys. If you move to the next slide. We also, and this work has really been led by Alona Tosca in South Africa, but we also see really strong impacts of social protection for the HIV-positive adolescents. And we've been really focusing on the negative and how we can protect them, but it's essential also to understand that those who might be passing on the virus. And again, we see very similar impacts. And again, parental supervision or monitoring and access to free school was really important. But what also came in here for HIV-positive adolescents was having a clinic environment where people were respectful towards them. So sensitive clinic care was actually just not being shouted at by clinic staff. And this is looking at girls, adolescent girls, and the last time they had sex, whether that was unprotected. And we can see that with none of those social protection factors, 50% were having unprotected sex, whereas with all three, that was only 9%. So it seems that for the positive, it's not just cash and care, it's cash, care, and clinic. If you move to the next slide. We've also been looking at another crucial health behaviour, which is essential for not only survival of positive adolescents, but also transmission of virus. We know that keeping viral load is essential for reducing transmissibility, and we also know that adherence is essential to that. And we see, again, parental monitoring, having enough food, and here attending an HIV support group. The combination of those three increased rates of adherence from 46% to 82% in the past week. But what's interesting here is that some of these rates were very low. So for example, whilst about 70% of the adolescents had enough food to eat daily, only 5% of the adolescents were going to a weekly adolescent support group or any support group for HIV. If you move on to the next slide. We also really wanted to try and understand how social protection works, because people were asking, you know, you put in a cash transfer and some help and then you get out HIV risk reduction. How does that work? And who does it work for? And I'll just very briefly talk about this. If you look to the left, you can see that we found that there are very clear linkages from structural deprivation. That's things like community violence, living in an informal settlement, having an AIDS-affected parent, which increased rates of psychosocial problems in families, and which on from that increased rates of HIV risk behaviour. What cash and care seem to do is two things. Firstly, they interrupt those middling psychosocial problems. So they reduce rates of abuse and behaviour problems and school dropout for adolescents. The other interesting thing that they seem to do is work more effectively for those who are most at risk. And this is unusual because many different types of interventions actually work better for those who are a bit less risky. But social protection seems to work the opposite way. For those who had the greatest levels of structural deprivation and psychosocial problems, particularly cash, had the greatest impact. If you move to the next slide. We also, and this really came from colleagues at UNDP, such as Doug Webb, and colleagues at UNICEF, Tom Fenn and Pat Lemarquin, really needed to examine beyond just the HIV agenda, but how social protection might impact multiple SDGs. And we see here again that combinations of cash plus care seem to have major effects. So interestingly, care provision reduced rates of hunger amongst adolescents. Cash provision primarily reduced rates of school non-enrollment amongst adolescents, particularly impactful for girls. Cash plus care reduced rates of substance abuse for both boys and girls, and we see a very clear importance here of the combination of cash plus care. This is interesting because there were worries that cash provision would increase alcohol use, but the evidence doesn't show this. You move to the next slide. We see cash plus care reducing rates of sexual violence and exploitation and violence perpetration, which was a great concern. We also see that cash reduces rates of teen pregnancy and mental health problems. So we can see that social protection is not just impacting HIV, it's impacting a whole range of sustainable development goal outputs. If you move to the next slide, please. So just a brief summary of some of the most recent data that might be coming up and that we might be thinking about. The Zambia trial, which we all know from 2012, found reduced HIV prevalence for cash transfers, whether those were unconditional or conditional. There were no differences. But two recent studies on conditional cash transfers have shown some mixed results. Audrey Pettifor's study in South Africa found reduced levels of HIV risk behaviour and gender-based violence, but overall in the whole study, whether they were in the control group or intervention group, they had very high rates of school attendance and low HIV incidence. And one of the potential reasons for this, the authors hypothesized, is the levels of attention and care that all of these adolescents were getting in the study. If we look at Qureshi Abdul Karim's study, also in South Africa, there was reduced levels of HSV2, herpes simplex virus, for those receiving a cash transfer conditional on extracurricular activities and school performance, but again, lower HIV incidence overall. Ashu Handa's work with UNICEF in Kenya shows very strong impacts on pregnancy and sexual initiation of the HIV, of the OVC cash transfer, but didn't have biomarkers. But it does seem that this is very reliable and correlates with what the other studies have found. It may also just be not feasible to use HIV incidence as a biomarker outcome for adolescents because the rates of incidence are not quite fast enough to meet to match the randomized control trial methods. But that's a question for debate. We move to the last slide. So what are some of the things coming up? First of all, Lorraine Scher has been leading some really fascinating research on cash plus care for younger children, and she's graciously allowed me to show one of the findings from this on the right. You can see that receiving a child grant has a major impact on school performance, but that's particularly for HIV-positive children. It's not impacting the negative children as much, and that's a real next step for us to look at. There's also some interesting work being done by Catholic Relief Services on cash plus care programs for reintegrating institutionalized children. We're starting some work on trying to understand the next generation, so the children of our HIV-positive perinatally and postnatally infected adolescents, and how social protection may or may not be helping their development. There's also some great work being done by Aspire's FHI 360 and USAID, where they're looking at household economic strengthening and HIV. And there's a randomized control trial underway, but also a really interesting evidence review which should be published soon. So if you move to the last slide, I'd just like to really thank our funders and to say that, and there's one more, that as we end, what we shouldn't forget is that we need to be engaging HIV-positive adolescents themselves and HIV-negative adolescents in thinking about how social protection may be made not only effective but also right for them. And some of the work that our teen advisory group and qualitative work have been showing that they are also thinking about social protection in multiple ways. And we need to listen not just to the data, but also to them. Thank you.
Thank you, Lucy. Thank you very much indeed. We will now invite Paul to make your presentation.
Yeah, thank you very much. And thank you for the opportunity to be part of this panel. And thank you, Lucy, for really wonderful presentation from a very fascinating set of research findings which already reflect, as far as I can see, the next generation of impact evaluations related to cash transfers. I think the findings, they really have a great potential to inform policy, and in particular social protection policies. And in my presentation, based mainly on experiences in Zambia, but also reflecting what I think is the situation in other countries in the region, I will try to link some of this available evidence on the one hand with the policy and practice situation in the region, and in particular in Zambia. Next slide, please. So we know that in the region, in the Eastern and Southern Africa region, many countries have either recently adopted or are actually now developing social protection policy or social protection strategy or social protection plans. And that reflects a strong momentum for social protection. And one other sort of indicator of this movement in the field of social protection are expanding cash transfer programs, which usually form the cornerstone of these new, broader, comprehensive social protection policies. But still, had to really make a comprehensive social protection policy work and to establish it, and the reality, I think, is still a bit harsh. No, there is still very much, in particular in public administrations, a culture of working in silos, coordination is weak, programs remain fragmented and often with low coverage, and also with inadequate funding or financing. And these are bottlenecks not only for comprehensive social protection policies, but also for social protection policies that actually facilitate combinations of interventions and linkages, which is one of the key sort of recommendations emerging out of the available evidence today. And I think we learned a few things also from how we can support these policy processes and how we can actually build comprehensive, coordinated and coherent policies that facilitate integrated interventions. And I think what we learned is that throughout the policy development process, we need to make sure that there is broad representation of various government agencies, but also non-governmental actors that represent, that deliver actually the various interventions, of which the combination we now know has more results, delivers more results than standalone interventions. We also know that it is very critical right from the start to strengthen coordination mechanisms and to make sure that the right incentives exist for strong coordination. Integrated programming, a capacity to really program in an integrated manner often is lacking and needs to be strengthened. And finally, I think, yes, there is an increasing body of international evidence that countries often can use, that is available to them, but it is very powerful also to have evidence available from the country itself when it is expanding a cash transfer program or when it is expanding a social protection policy. These are a few things we learn. Now for cash transfers in particular, we know, and that has been amply demonstrated in the literature and already through Lucy's presentation, cash transfers have a demonstrated impact on the pathways that reduce HIV risk, whether it's through education or through income protection. We know that. And we also know from the available evidence that cash transfer interventions can be optimized basically in two ways. Combining a cash transfer intervention with another social protection type intervention, whether it's livelihood support, social health insurance, or fee waivers for education, for instance. And secondly, combining a social protection intervention or a cash transfer intervention with basic social services in health, nutrition, education, or with complementary programs such as a parenting program. And basically this second point refers to strengthening supply side delivery of services that is necessary to optimize the impacts that we already see from cash transfers, but often to a certain extent. Finally, I think what we have learned also that cash transfers had to have the impact among the groups that we actually aim to reach out to, that broad categorical targeting is now most likely to be inclusive of the vulnerable groups that we aim to reach. Furthermore, broad categorical targeting leads to less exclusion, we know that. It can even often be delivered at a lower cost. It is less prone to stigma, and it is also doing justice to what we also see from the evidence base, is that cash transfers actually address a very broad range of development impacts. So broad targeting is helpful in order to optimize that. So this is what I wanted to start with, some broader implications for policy of what we know about cash transfers and social protection interventions. Next slide, please. And this is an example that I wanted to share on how the government of Zambia has tried again to optimize the impact of cash transfers with the objective to increase utilization of HIV-related services. Now, Zambia adopted a broad comprehensive social protection policy back in 2014, and at the same time, in that same year, it started more significantly fund its national cash transfer program, which at that time also started to really expand to reach a meaningful coverage. And at that time also the government saw the opportunity to build on that expanding cash transfer program, to strengthen linkages with other services, to optimize its impact in the fields where it wanted to see impact. In this case, increased utilization of services. Now the HIV and social cash transfer linkages was the first in Zambia. It started in 4 districts only, and now it is being rolled out in 15 districts. The focus really was to see how can we at the district level operationalize such a linkage, make this combination of interventions happen and have it produce the impact that the government aimed to see. So the focus of this initiative was very much on learning. How do we do it? How do we coordinate? How do we monitor? What types of interventions are best fit in the districts? And the interventions themselves were also very much developed with officials, officers in various sectors within the districts. And so the main sort of features of this attempt to operationalize the linkage between the social cash transfer and HIV services was first of all to strengthen the capacity of health professionals and health extension workers to deliver adolescent-friendly HIV services, not only that, but also to deliver these in an adolescent-friendly way. And I think Lucy also referred to that very critical element of service delivery in her presentation, and the supply side strengthening. Secondly, the aim was to train and to strengthen the capacity of community welfare assistance committees to enable them to refer adolescents to the services that were delivered from the health clinics. Now, these community welfare assistance committees, they were actually the volunteers that were members of these committees. They actually do deliver, they do target, they have a targeting function under the cash transfer program, and they also monitor payments delivered under the cash transfer program. So they know the beneficiary families, they know the composition, and they have regular access to these families. For instance, every second month when payments are being delivered to the families, but also more regularly as they go around to monitor and try to identify vulnerable situations. So using that opportunity, that platform, to strengthen their capacity around issues of HIV and around issues of referrals to services. In addition then to interventions focused on the two sectors, health and the social welfare sector, there were also attempts in this linkage effort to enhance the demand for services through more community-based, community-wide approaches, peer-to-peer approaches, using community drama groups to get messages out, and messages related to HIV type of information, but also to services. And finally, now given the importance to learn in this initiative, there was an attempt to strengthen data collection at the health facilities by introducing changes to collect more disaggregated data related to age and gender. And there was an attempt to a little bit more structurally assess the changes that we saw happening during the implementation period of this initiative. And the main tool used there was a knowledge, attitude and practice survey among adolescents that lived in cash transfer beneficiary families. And I just wanted to share, next slide, a few summary findings from that knowledge, attitude and practice survey. Not a rigorous experimental design type of evaluation, definitely not. More a tool that was used to get a proper indication, are we on the right track? A baseline implemented in December 2015, and what we called an end line, a follow-up survey implemented in July 2016, about 6 months, 7 months after, among 500 adolescents in the sites that were benefiting from this initiative in 4 districts. So what we basically start to see there was some small improvements in terms of comprehensive HIV knowledge, actually less than we expected, and sort of indicating that the package of intervention was probably not the best fit to address this particular factor. But if we look at other variables, such as the proportion of adolescents that use health workers now as a source of HIV information, that did actually increase to a much larger extent and reflected the attempts to strengthen the capacity of these health workers to actually act in an adolescent-friendly way as a source of HIV information. Next slide. We also saw an increase in condom use at last sex, again among those adolescents from social cash transfer families. And finally, we saw an increase in the proportion of those adolescents that used HIV testing, and that again sort of confirmed that this initiative was on the right track by using community welfare assistance and strengthen their capacity to refer and to share information with adolescents about the availability and usefulness of these services. Again, this was just one measure point, and this will be repeated again in the future, but enough to learn from it, together with other information from monitoring visits, data at the health facilities, to convince the government at that point in time to extend the initiative from the 4 districts it was being implemented in to 15 districts that are being covered now. And the last slide, please. So just very briefly, what did we learn from this initiative to operationalize this linkage, this combination of interventions, that expanding cash transfer programs, and that is not a situation exclusive to Zambia, but a situation which we see elsewhere in the region as well, that it really constitutes an opportunity because these cash transfers, as they need to be delivered to vulnerable households, require a stronger social welfare sector. And by strengthening that particular platform, it becomes an opportunity to use that platform to also have these volunteers or officers deliver other services, strengthen referrals, case management, etc. So that is one thing that we clearly saw as an opportunity. Secondly, as I said in the beginning, seeking linkages, combinations of interventions, very often at the minimum require strong coordination, which is not obvious. This initiative worked well in a certain number of districts, but in other districts we saw that coordination between the health sector and the social welfare sector continued to be something that was not obvious to the officers, and that really required strong thinking about what type of incentives and what type of analysis we could produce in order to improve that. Thirdly, it is all about linking vulnerable adolescent boys and girls to services and not making services exclusively available to adolescents in cash transfer families. No, services are always available for the entire community, but the attempt that is being made is to avoid that the most vulnerable adolescent boys and girls, often in cash transfer families, are excluded from those services or do not have access to those services. It's an important principle. And finally, one lesson learned is that in a resource-constrained environment, whether the resource is finance or human capacity, weak systems, weak service delivery capacity, operationalizing a linkages best benefits from what we call modular intervention packages. Now, in a resource-constrained environment, you can say, okay, the minimum package where we know that it works constitutes of interventions A and B. If there are more resources available, the best top-up interventions are C and D. So again, in choosing between these type of packages requires more evidence, and their more rigorous impact evaluations are probably among the next generation that Lucy referred to. Yeah, and that is what we believe as the way forward, to continue collect evidence on these type of cash plus approaches in the social protection environment. Thank you for your attention.
Thank you very much indeed. That was a really experience-based presentation, and thanks for bringing examples from Zambia. Thanks so much, Paul. Before we go on to the next presentation, I just want to encourage you participants, please put your questions on the chat box, and please know that you can also download the police brief on the handout session, which will be on the webinar. And we now want to invite Jason Wolf to give us the next presentation.
Thank you, Noreen. So as Noreen mentioned at the outset, I am speaking from the perspective of a donor. I currently sit with the Bill and Melinda Gates Foundation, and previously spent a long time working on the PEPFAR program for USAID. Let's go on to the next slide. And to be clear, what I want to share with you all today is sort of a synthesis of my my perspectives as a donor, both on the PEPFAR side and the Gates Foundation side. But to be clear, I am not speaking for PEPFAR or for the foundation. I'm just speaking about sort of my own views and experiences in this space. And so from a donor perspective, what I want to talk about is the DREAMS program as well as beyond DREAMS. The DREAMS program, as probably many of you know, is an initiative, a partnership really with PEPFAR and the US government, the Gates Foundation, and a bunch of others to reduce incidence of new HIV infections among adolescent girls and young women in 10 countries in East and Southern Africa in a very short time period. It's a giant initiative, very complex with a lot of moving parts. And DREAMS, as it was designed and is currently being implemented, I would say was heavily influenced by a lot of the work that Lucy very briefly covered for you all. And I wanted to tell you a little bit about that. Next slide. So at the outset of DREAMS, we were given the charge to develop a core package of intervention, sort of a menu of things that could be done through the DREAMS program that were evidence-based and were highly effective to achieve this result of reducing new HIV infections. And we knew it was going to take multiple interventions, which was a very important principle at the beginning. And we knew we really wanted to look at high quality structural interventions, not just looking at biomedical and behavioral interventions. But when we started looking at the evidence and the literature for some of the most common kinds of cash type interventions, when we looked at cash transfers, we obviously saw some very good outcomes that have been achieved there and documented in the literature. And Lucy touched on a number of those studies. So that was sort of a quick win to include that in the core package. But as we started to look more broadly beyond just cash transfers at other types of economic strengthening interventions, we saw a very different picture, a very mixed picture in terms of effectiveness. But based on at that time sort of fresh, hot off the presses outcomes, findings of some of the research that Lucy talked about, we took another look at the literature with this idea of looking at interventions that reflected combination approaches versus those that were very standalone, just looking at a cash type intervention. And when we did that, we saw a much different picture, and we saw how those types of combination approaches could be highly effective and really work in the context of DREAMS. And that allowed us to include those types of interventions in the core package for DREAMS, which was very important for us. Next slide. And so the results of that, what I talked about is including some of those interventions in the menu, but it was still up to individual country programs and their partners to decide exactly how they were going to design DREAMS in their particular context. And this is somewhat old information, but it's information that's in the public domain, which is good, to give you just sort of a flavor, a sense of how this actually worked out. And what you'll see is there are three broad categories of interventions: strengthening the family, empowering adolescent girls and young women, and reducing their risk, as well as mobilizing the community for change. And those three broad categories, I think, really help to reflect a broad social ecological approach that involve both the girl or young woman herself, her family, and her community. Which I think is very consistent with the things that Lucy was talking about. You'll also see that about roughly $1 out of every $5 in DREAMS funds was actually invested in brand new cash plus care plus classroom interventions for adolescent girls and young women. Those are the yellow slices that you see over there, including parenting programs, cash transfers, education subsidies, and combination socioeconomic approaches. Also very importantly, existing national social protection platforms provide both benefits in their own right, but they also, in the context of DREAMS, have provided a really important channel for layering additional interventions for girls and their families. In a number of countries, that has been a sort of launching pad for DREAMS, is looking at who is being reached through national cash transfer programs or other existing social protection measures. Knowing that sort of the cash intervention is being met through that, now what kinds of care, or in this case classroom interventions, can we layer on top of that? Next slide. So now I also want to talk about things beyond dreams. Dreams, I think, is a very good success story in operationalizing all of this new evidence, really putting it into practice. But what other opportunities and challenges might exist beyond dreams? Next slide. So in terms of opportunities, Lucy talked about some of the very new research that is speaking to good opportunities and outcomes that can be achieved for adolescents living with HIV. And I think that remains an area that is, I think, less explored, less taken advantage of by donors at this point. And I think there's lots of opportunities there, especially in an environment with much greater emphasis on differentiated care and treat all or test and start kinds of policies being put into place. Obviously, many of those things are targeting adults as opposed to adolescents and children, but I think that as those new measures come into place, it's really going to shine a light on some of the challenges that we have around adherence and loss to follow-up, and create new opportunities, new imperative for more and better programming at a community level, which I think creates space and opportunity for new thinking to be brought in and leveraging the types of findings that are coming out of the research that Lucy talked about. Similarly, one of my big takeaways from all of this work is not just the idea of combination interventions, but the fact that these interventions actually touch on different levels. Some of the interventions are working with children or adolescents themselves directly. Some of them are working with their caregivers. Some of them are working with teachers or doctors and nurses within clinics. It is very reflective of that social ecological approach. And I think that creates new opportunities to expand how we are using family-centered approaches in what we're doing. If we're already working with caregivers, what new things can we layer on that will benefit their children as well, and vice versa. Also, these types of combinations that both Lucy and Paul talked about that we know work, or we think might work, or we're still scratching our heads around what are the best combinations to use. I think those combinations are going to change over the life cycle of children and adolescents, depending on their ages and stages. And I think there's lots of opportunities for us to think about what are those combinations that we should be thinking about at those different ages and stages, and how might that change over time as they grow up. Lastly, coordination is a giant challenge in all of this. How do we bring together these types of combinations and layered interventions and bring them to bear with the same family and the same individuals? I think this creates a giant opportunity for strengthening and improving case management approaches in a way that in the past may have not been as that policymakers and donors may have not quite seen the need coming from a very public health type of perspective. But with opportunities also come challenges, and I really, despite my enthusiasm for the research that's been done and the new policy and practices that we're seeing happening on the part of donors and governments and implementing partners, there really are a lot of challenges out there that are going to hold us back from doing more. And I think it's very important for us to acknowledge and discuss what those challenges are. Lucy always does a fantastic job of coming up with very alliterative ways of talking about her work, such as cash plus care plus classroom plus clinic. So I decided to take a page out of her book and try to do the same thing. The challenges as I see them fall into sort of these buckets that you see here: evidence, economics, equity, epidemiology, exposure, and exit. In terms of evidence, Lucy already touched on this. The work that she's been involved with and work that many others have done have really shown great success that can be achieved. But at the same time, we have other studies and bodies of work that have shown mixed results or poor results in this area. And from a donor perspective, it can be very, very challenging to make sense of conflicting evidence and figure out a way forward or commit to a way forward in spite of that. So there's much, much more work to be done there. As Lucy alluded to as well, there's also, I think, a lot more work to be done to understand some of these pathways towards change, how different combinations might be working and working best for whom. Economics is also a giant issue in terms of who is going to pay and how much are they willing to pay. A lot of the work, and I think Paul illustrated this very well in the examples he gave from Zambia, really build on national programs that have been set up for broad poverty reduction or social welfare types of purposes. More specialized donors such as PEPFAR are very interested in how they can fund add-ons to that, but somebody still has to pay to set up and to operate that overall platform. And that can be a giant challenge to figure out how donors interested in very specific pieces might be willing to pay for the overall platform. Equity and epidemiology, in my mind, kind of go together. In terms of social protection, we are preoccupied very heavily with the idea of inclusiveness and equity. Many of the governments that I have worked with are also very, very passionately concerned about making sure that the work that they do is equitably distributed throughout their country. But epidemiology, and when we're thinking about HIV, those who are affected by HIV, those who are living with HIV, it tends to not be equitably distributed throughout the country. They tend to be concentrated in certain places. And HIV dollars, really want to flow to those places and saturate those places. And that can be very difficult to reconcile with the equity principles and concerns that drive broader social protection work. Lastly, exposure and exit, in my mind, also go a little bit together. I think we still have real questions about how long children and adolescents really need to receive these types of cash plus care interventions in order to sort of sustainably achieve outcomes. There has been certainly recent work lately that is showing that that cash plus care is not sort of a one-off intervention. It's something that people really need to be exposed to for a fairly long amount of time in order for it to work. And there's not necessarily anything wrong with that. Sometimes we just have to adjust our expectations about how these types of interventions actually work. But it kind of goes back to the economics in terms of how are we actually going to be able to afford to do that at scale. I think that there are good innovations and good ideas for how we can try to do that, but I think we have to acknowledge that it is a real issue for us right now. And lastly, in terms of exit, a lot of national governments and their social protection work are very interested in graduation type models of how they can responsibly exit beneficiaries, families off of, in particular, cash transfer support. But that may affect the type of exposure that the children in those families receive on the care side and so forth. Reconciling those kinds of priorities is, I think, a bit of uncharted territory for us. And it's a challenge that I think we need to continue to wrestle with. That's it for me, but I look forward to more questions from you all for further discussion. Thanks for the opportunity to share my thoughts with you today.
Thank you, Joyce. Thank you very much indeed. We have apologies from David. Apparently, he is not able to make it. We will be sharing his slides with you. But for now, what we'll do is to go straight into the question and answer session. we've received quite a number of questions right now. I'll read the first one, which came directed to Lucy Kluver. Did the research also look at the role of social service workforce in the provision of these services? And that was from Nicole Brown. The same question has been asked to you, Paul, as well. So maybe you need to, let's hear your responses on that.
Yeah, this is a great question, and I should have addressed this. We included a whole lot of questions on social service receipt, but also on community-based services like home-based carers, school counsellors, a whole range of services that we thought that teenagers might be accessing. Unfortunately, and this was a sample of 6,500 adolescents. Unfortunately, the rates of actually receiving those services was so low. For example, I think only 9 children were receiving home-based care services, that we actually couldn't analyse them. So it's a really, it shows us just how important it is that we expand these services, but unfortunately the rates were just too low to analyse, and which may itself be a massive message. Thank you.
Thank you. Paul, would you want to respond to that?
Sorry, there was an interruption and I couldn't hear your question.
The question is, did the research that was happening look at the role of the social services workforce in the provision of those services?
Okay, thank you. The research as such, because it was a very light research, did not. But as I tried to explain, the intervention definitely looked at the role of the social welfare workforce, mainly because the assumption we had is that an expanding social cash transfer program means a stronger platform for the delivery of cash transfers that can be used by the social welfare workforce, and mainly volunteers in Zambia, to deliver other services or to act as a referral mechanism. Thank you.
I have 2 more questions, Paul, for you. From Jackie. She says, I see a lot of focus on Ministry of Health capacity and very little activity towards the children's offices in Zambia, for instance. Why is that the case?
Yeah, I wrote something to that question in the chat box already. Yes, there was a strong focus on health capacity, precisely because at some point you see limitations as to the impacts of cash transfers alone in terms of impact on HIV risk. And that's why our assumption was that we can optimize that impact by strengthening the supply side response, which is in this case mainly the health sector. Now in terms of enabling access to services and linking those vulnerable adolescent boys and girls to these adolescent friendly services, that's precisely where we thought the social welfare sector can play a role, because they tend to have better access to those vulnerable households than the health sector or the health extension workers. So it's both.
Thank you, Paul. I will come back to you again with a question from Professor Shea. A core component of the Zambia system you described relies so much on volunteers. Is this good practice and is it sustainable?
That's a very good question. I think it's, yes, it's correct. The social welfare sector in Zambia, in terms of professionals like social workers, basically ends at the district level. And because of resource constraints, a vast country, a vast area to cover, and a thin government, there is no formal social welfare capacity below the district level. So government relies on volunteers. Now, of course, ideally, they would rely on professional social workers or parasocial workers. And there are initiatives ongoing now to strengthen this volunteer base by providing them with incentives, by providing them with training, and to have them to try out to what extent they can assume certain roles that would normally be roles of a social worker, but with all limitations. Of course, literacy rates are low, completed education levels are relatively low. So this all needs to be taken into account when we explore how to best make use of this volunteer base.
Thank you very much. Jason, a question to you from Deki Onyando. I see dreams, they were elements of conditioning, that is education and STI. Why was that when evidence earlier presented in the first presentation showed no difference between conditioning and unconditioning?
Thanks. That's a great question. So the reason that you saw that on the slide is because when we did our literature review, we decided to categorize cash transfers according to whether they were conditional on school attendance, conditional on things like STIs, for which there is a small body of literature, or unconditional, rather than lumping them all together just as all types of cash transfers. And the reason that we did that is if you, when you get the chance, go back and look at that slide, you will see that our evidence reviewed showed good, compelling results for us for both the school-conditioned cash transfers as well as the unconditional cash transfers. The cash transfers conditioned on things like STIs actually showed some mixed results, which allowed us to take that off the table for dreams. Again, as I mentioned, the core package for dreams was sort of a menu of things. So what it was saying is under dreams, you could do school-conditioned cash transfers or unconditional cash transfers. We actually gave other guidance under dreams, strongly encouraging countries and programs to consider unconditional cash transfers because they do work very well, and in many ways they're much more feasible and cost effective to do. And it's what most of the governments in dreams countries were implementing at national scale to begin with. So sorry for the confusion there, but I hope that little explanation clarifies things for you.
I'll just get back to you again, Jason, from Banele Mandaza. Do you foresee the funding landscape focusing on increased cash transfer funds in order to boost social protection activities in countries that are really economically challenged? And if so, how can these be structured?
I'm sorry, Noreen, I missed the very first part of that question. Could you repeat it?
They want to know whether you foresee the funding landscape focusing on increasing the cash transfer funds in order to
okay.
social protection activities.
Yeah, it's a good question. You know, there are a number of donors who have really led the charge on work in this area. That certainly includes, you know, UNICEF. It includes other donors like the World Bank and DFID. The donors that I have worked for, the U.S. government and the Gates Foundation, have been much further behind other donors in that space. I don't see that situation really changing in the near future in terms of which donors are sort of leading this work. But I don't have any insider information to have a sense from these other donors, you know, World Bank and DFID and so forth, how their funding strategies may be changing or not in this space. I certainly hope not. I certainly hope they continue to provide the leadership and financing that they have in this area. We've all benefited tremendously from it.
Thanks so much. I will now probably have the last question, which is from Emeka, who is from REPSI. In limited resource settings, what are the sustainable strategies for using cash transfer as a means of retaining adolescents in treatment and care? And that is directed to Lucy as well as to Paul.
Paul, you go first.
Okay, I think that's a difficult question. It links a little bit to the previous question. My view is that first and foremost, it is very important that countries think of how they can domestically finance cash transfer programs. Cash transfer programs, when they are established, are policies and they are there forever in principle to protect and help vulnerable groups, you know, meet minimum standards of living. And often we see that even in nationally macroeconomically constrained resource environments, there are options for those countries to finance cash transfers. You typically see that there is expenditure as well on much less effective and much less progressive social protection interventions, funding that can be channeled to cash transfers. For instance, in Zambia, a fuel subsidy was reduced and the funding was used to scale up further the cash transfer program. Now, strengthening supply side services to even further improve adherence is also a question of now balanced funding in the health sector, for instance, and optimizing funding to optimize those linkages. That's a complex one, and I wouldn't not immediately know the answer on that one.
Well, thank you. I think this is a great question, and it's really at the heart of the research that we're doing right now. We've just finished collecting data on the world's largest sample of HIV-positive adolescents, and we're trying to understand what can best improve their adherence. And we're really finding some very strong results. For example, we're finding that one of the greatest predictors of non-adherence for adolescents is abuse and violence that they're experiencing at home, at school, and potentially in the clinic. And we're also finding these strong impacts of what goes on in the clinic matched with very strong impacts of what's going on at home and the economic and psychological support that teenagers are being given. And I suppose what I'm saying is that we're going to need to think if we're really going to improve ART adherence for adolescents, which is a major problem that we have not yet cracked, we're going to have to focus on this with all the effort and attention and research and policy energy that we have been doing for HIV prevention. We can't just let this go, because children and teenagers are dying, and we need to understand not only the broad picture, but the specific combinations which are going to be most effective, and how we can most effectively and speedily put those into policy and programming. So I think you've just given the next webinar questions, and hopefully we'll be able to feedback on that within the next few months. Thank you.
Thank you, Lucy. Thank you, everybody who managed to stay on the webinar. These were very, very helpful presentations that we got. Wonderful indeed. Thank you, Lucy. Thank you, Paul. And thank you, Jason, for sharing your expertise. We have had a lot of questions being posted on the question chat box. We will try by all means to invite all the panelists to answer the questions, and we'll post on our Twitter as well as on our website. On our website, we'll be posting the questions and the answers as well. Some of you were asking for the presentations. Again, these are going to be posted on the webinar, and you will be able to access them. You will also be able to access the policy briefs that Lucy provided. We would also like to take this opportunity to thank Riyadh Issa and the Coalition for Children Affected by AIDS for hosting this event. We thank you, all our sponsors and our wonderful panelists. Again, I wish to thank you. This marks the end of our webinar, and please follow us on Twitter at Riyadh Issa and at Children and HIV on Twitter, as well as follow the conversation on #social protection. Thank you all. We'll be meeting again in the next presentation. Thank you, Naomi. Thank you, Angelita.